Why do you think it's the case that most economists favour explicit rationing?
Okay, I think the reasons behind favouring explicit rationing are sort of twofold, really. One is a philosophical view that accountability, openness, transparency is an appropriate way to run a health service, and I think that's a view that is held not just by economists but by lots of people. I think also that for economists particularly, the sorts of methods that economists advocate for rationing are methods that that you need openness and explicitness to operate. So, for example, methods like cost utility analysis and PBMA and so on are all methods that for allocating resources that require a certain level of explicitness. They don't necessarily require explicitness at the level of the patient, but they do require explicitness at higher levels, and for certainly the sorts of decisions made by NICE, there is the potential really for explicitness at the level of the patient as well. So I think many of the things that we do as economists, it's hard to do if we don't have explicitness within the health system in terms of rationing.
In 1997, you published an article that suggested that there might be negative aspects to explicit rationing. Would you like to elaborate a little bit about what you meant by that?
Okay, so that piece of work really focused on the disutility that there might be associated with the process of rationing healthcare. So when we do a sort of quality type analysis or a willingness to pay type analysis, what we're looking at is to maximise the total utility that we get in terms of the outcome of that healthcare rationing. But what I was considering was whether there were aspects of the process of rationing, when it becomes more explicit, that might impose disutility on people. So I thought about it in two ways. The first one drew on the work of Gavin Mooney in relation to deprivation disutility, which is the notion that people may have greater disutility if they know that they're being deprived of a particular thing. So Mooney looked at it in relation to antenatal screening and whether people felt a greater sense of disutility if there was a screening test available but they'd not been able to have that screening test. And I applied that within the notion of rationing to think about whether or not if people know that they aren't having care but that X person down the road is or Y person down the road is, that they feel more deprived of that care. And if you think about something like postcode rationing, actually that's a good example of where people do feel more aggrieved that they're in a particular area and they aren't entitled to something, and somebody down the road or on the other side of the road is in a different health authority, a different PCT, and they are entitled to something. So that notion of deprivation disutility arises from that feeling of being deprived of something that other people are getting. The second negative aspect to explicit rationing that I talked about in that paper was what I referred to as denial disutility, which is the notion that there may be disutility for the people actually denying the care to other people. So, for example, the doctors who have to turn around to somebody and say to them, you're not getting care, and there is care available, but you're not getting it because the health authority isn't willing to finance it or the PCT isn't willing to finance it. So that was the second type of disutility that I talked about.
So is there any evidence that these types of disutility exist?
Yeah. One of the things that I did within my PhD was to try and look qualitatively at really at the citizen-agent relationship and the whole process of rationing within what was at the time a health authority. And it certainly resulted from that work that having to deny care had an impact on the healthcare system. So if you talk to both citizens or health professionals, what you can see is that some people say immediately they don't want to be involved in denying care to other people. And those people who certainly from within the citizenry, who were willing to be involved in denying care, actually weren't willing to be involved in denying care because they were very much, well, actually it's not denying care, it's just putting people low on a waiting list and they'll get there eventually. So there was certainly evidence from the citizenry. And then if you look at the health professionals and the whole system within healthcare, you can start to see that the denial of care actually influences how, or the unwillingness to deny care, the disutility that's associated with denying care, impacts on the decisions that are eventually made. So what I found with that work was that the health authority was agreed by everybody really to be the group that were acting as agents for citizens or for the public in terms of making decisions about what would be the appropriate allocation of resources across the whole health authority to achieve their objectives, and in a sort of objective way, but that there were influences on them in terms of their decision making from both government and from clinicians who stamp their feet and say this is what we want. So those things impacted on the actual decisions they made, but also as they went out to the trusts, the trusts themselves diluted the decisions of the health authority, so that generally they altered decisions towards life-saving care and away from other types of care, because they didn't want to deny care, particularly life-saving care, to individuals. And what was particularly interesting was that then happened with the collusion of the health authority. So they would say things like, well, we know that we give the money to the trust and this is what they're supposed to do with it, but if they can find money within their budget to do those other things, that's fine. So that's there was a real system of sort of collusion and equivocation around the denial of care, and I think denial disutility certainly played a part in that. In terms of deprivation disutility, less evidence I think on that, but one of the things that I did as part of my PhD was talk again to citizens and health professionals about whether they would want to know about any denial of their own care, and most people said that they would want to know, and mainly they'd want to know either so they could change it through protest or they could change it through paying for care. There were a few situations where people said they wouldn't want to know for one reason or another, and then I've had a PhD student since then who's done work looking actually at patients' perceptions of rationing of their own care, because one of the problems with the work that I did was that it was very much at a public health professional level rather than actually talking to patients who were currently going through that process. So Amanda Owen-Smith did some work with me looking at breast cancer patients and patients with morbid obesity to look at the process of the denial of care and how they dealt with that denial of care. And again, she found sort of quite similar things in that people understood the need for rationing and they were happy with the idea of rationing at a citizen level, but when it was them themselves whose care was being rationed, when they knew about it, they wanted to do something about it, and that caused quite a lot of stress for many of them. So people who had to go through exceptional funding processes and so on, particularly if they were unsuccessful, found that very stressful. Some people paid for care. Some people did accept the rationing or eventually accepted the rationing, but certainly there was a sense that that people did feel hard done to as a result of not getting care that they knew was available. I think it's different if there's just nothing available than if it's available but you can't have it.